So we go back to the issue of public health policy, especially after the president announced that we are reducing the alert level to level 3. We talk about this issue now with Professor Alex van den Heever, who is at Wits School of Governance. A very good evening to you once again, Professor. I do apologize for the poor quality of sound, but we were talking about the public health approach. The fact that it would seem that it's the 82% of COVID-19 cases that are mild cases, but you were saying the 9% that are in intensive care, that they need extra care. How do we do that in level 3? And how do we compare level 3 with level 4 when it kicks in?
First of all, the lockdown itself as a health prevention mechanism was not very useful in suppressing the epidemic, although it had some public health effect. But the most important thing now is to suppress the epidemic as far as possible to keep people from surging, the sort of inpatient usage to surge, which might happen if we lose control of the epidemic. So even with that ratio of a relatively small number of people who are at risk of severe morbidity and mortality, it's enough to cause significant deaths in South Africa. So we do have to protect the health system from that, and we do have to make sure that we are in a position to treat the people who do become sick and treat them effectively. But the best is to prevent. But we won't be able to use the lockdown to prevent, but we do have other measures, and we really should be intensifying those measures over time while still keeping the economy open.
And I'm glad you say that, we won't really be able to do much of that, the prevention, because we've seen that people have already started acting as though we are in level 3. You've seen a lot more cars on the roads. People are still continuing to not adhere to the guidelines in some areas. As I mentioned, the hotspots earlier on, we've got the mining communities. So how are we going to do that, especially in cases where it's been said over and over again that people are asymptomatic, make it very difficult to get a clearer picture of who's affected and to have the real figures?
So we do have the difficulty that the lockdown didn't entirely suppress the epidemic, which it had in many other countries, up to a point. Our other alternative measure that would be consistent with managing the risk in our sort of very densely populated communities would be testing and tracing. And that is, it's weak at the moment. It might be that we can escalate in a few months, but it is going to be difficult to manage. There is a lot of uncertainty about what faces us, but I don't think that the lockdown was necessarily going to address these kinds of risks that we're seeing. We have to manage them in situ. We have to deal with the high-risk areas through focusing on them, both from a prevention perspective as well as from a communication perspective. We also have to protect people in bulk transport when they arrive at work. We have to create conditions in which it's quite difficult for what are called super spreaders to exist. We need to take them out of the system as far as possible. But I think we really had no choice but to get into this position. We just have to manage it from this point forward. I don't think that the purpose or the intention should ever be to let the epidemic completely run away from us. But we are going to have to manage this on a week-by-week basis.
How do we ensure a rapid development and distribution of accurate testing and diagnosis? We saw at the SABC just the other day, a colleague in our KwaZulu-Natal offices was given a positive diagnosis when in fact he was negative. This also creates its own complications.
So we really do have a problem with the testing framework. On the one hand, there are going to be false positives. On the other hand, we don't have enough kits in South Africa, and we have an enormous backlog of tests at the moment. So what we're seeing in terms of new infections at this point in time is effectively the position about 9 days ago. So this is quite worrying in general, but the preventive effect of the testing regime requires that you are able to test people and take action. The false positive is probably worse than the false negative. But that's always going to be there. You want the testing regime to be mostly reliable. But part of what we don't have at this point is rapid turnaround times. We don't have tests coming back within the same day or within 10 minutes of the test, which is what we really do need. And we don't also have rapid contact tracing. We are going to have to continue to build this up as we go forward.
The public health methods that were used initially when we were coming to terms with what COVID-19 is, who is vulnerable, and obviously ensuring that people self-isolate, quarantine those who are worse off. Have we bettered those? And is there something that we're not doing that we have seen from international best practice that we should be doing?
We are doing quite a lot of what other countries would do. The problem is that we have a social context which is quite complex. We have very concentrated communities, very densely populated areas. And those areas, people find it quite difficult to socially distance. And we therefore need to apply methods that work in South Africa, whereas another method would work perfectly fine in the United Kingdom. It's not going to work in South Africa. So we do have to target particular areas with interventions. But there is also feedback that in a number of settings, people are saying they don't believe there is a virus. They don't believe that it is serious. They're not seeing a lot of death in their area. And sometimes that's a problem in epidemics, is that people only start to react when they see the epidemic take off amongst people they know and nearby, and only then they react. And unfortunately, that's too late in an epidemic. You need to react well before. So we've got a multitude of problems, and I think that we are going to face a situation where we need constant vigilance. I don't think it's because we don't know what can be done from best practice elsewhere. The problem is applying it at scale and in context. So we will have to just continue targeting the hotspots, targeting the areas where there are community outbreaks, trying to isolate people, and just keep the disease reasonably suppressed on an ongoing basis.
So how do we do that, reasonably suppressed, especially if obviously we're seeing cases increase exponentially at this point, and not every individual case can be attended to? What mitigation strategies should we be looking at this point?
It's quite difficult to say, because the key intervention is the testing and tracing and quarantining. And the problem there is that if the epidemic passes a particular threshold, testing and tracing ceases to be an effective preventive method, because you've essentially lost control of the epidemic. Given that we've essentially run out of runway for a lockdown, we also don't have that as an intervention, certainly a generalized lockdown. So much more targeted approaches are going to be required going forward. So it's not necessarily completely hopeless, but it is a concerning situation. We are going to have to target approaches at particular areas, and it may be that there's a requirement for selective lockdowns rather than generalized lockdowns, but only for a period in order to sort out a localized community-based outbreak and then pull back. But the generalized lockdown is out of the question. But there are very few other options that we have. I think that, without testing and tracing and going beyond a particular threshold, we're in a very difficult period. The Western Cape appears to have a more advanced epidemic than other areas, but we're also not sure, because with 100,000 test backlog, we don't really know what's going on in Gauteng, but we're only just starting to see the inpatients rise in the Gauteng area, whereas they're already very significant in the Western Cape. But we might be a week away from experiencing what the Western Cape is experiencing in Gauteng. So, unfortunately, all one can say at this point is that the best is to manage we know where the areas are of major outbreaks. We need to manage those areas on a targeted basis. We need to manage them without the ability to test on a massive scale. But we will just have to keep going on that approach probably for the next 2 to 3 months. as a way of managing the peak of the epidemic. You've got to keep it below the level at which it puts our health services under massive stress.
Thank you so much for speaking to us, Professor Alex van der Heever. He is with the Wits School of Governance. He is the chair of Social Security there. And